first of all, we need to look at the aims of cardiac surgery, heart surgery. And generally, these are to improve the survival of the patient, the quality of life of the patient, their symptoms, and also to reduce the need for their hospital admissions. So the indications for surgery depends on the different conditions. But in general, when the severity is significant, especially when the pathology is showing some effects on the heart, like causing the heart to dilate or the function to be poor, then that is the time for surgery. So, for example, there are various conditions like severe multivessel coronary artery disease, severe valve stenosis or regurgitation, aneurysms or dissections of the aorta, or cardiac tumors. So once the indication has reached for the surgery, the earlier the surgery is done, that is in an elective setting, the lower the risk for the patient. But some patients present a bit later, so surgery has to be done on an urgent basis when they're unwell. And in some patients, it has to be done as an emergency. These are the highest risk for the patient. So there's always a balance of the risk of the surgery versus the expected benefits of the surgery. In general, the patient has to be fit enough to undergo surgery and also has to have an expected life expectancy, which is long enough to see the benefits of the surgery. This is usually quite clear in the younger patients, but in the older patients, we will then have to balance the benefits of the surgery versus the risk of the surgery. Yes, so this is linked to the last question. So there are some conditions where it is very clear that surgery is needed to improve the patient's survival. For example, if someone is diagnosed with multivessel critical stenosis in the artery, then the clinical trials show that the surgery by bypass surgery will improve their survival in the longer term. And so in these patients, we can advise them that they can expect to live longer if they have surgery. And then some patients who are very symptomatic, for example, someone with severe mitral regurgitation, presented with shortness of breath, then when they are symptomatic with the disease, then we can also advise the patient that they have tried a period of medical treatment and they're still symptomatic, and the heart is already starting to get big and weak. And the longer we wait, the higher the risk of the surgery, and also the lower their life expectancy in the longer term. So we have to evaluate each patient. Some patients, it is quite clear because they are clearly very sick, they have limitations in their exercise ability or their quality of life. Some patients, they are asymptomatic, they have no symptoms, and the condition is diagnosed through clinical examination or through a normal medical checkup. And yet we know that in those conditions, if we leave it alone, their outlook is not so good. So we can then advise the patient accordingly. And some patients, on the other hand, have some options. So they may be diagnosed with severe aortic regurgitation, for example. We know the aortic valve is leaking very badly. But we know in that condition, we don't have to do surgery urgently. We can wait a while until the patient becomes symptomatic or the heart dilates to a certain size. So in those patients, we can advise them that clearly we need to control their risk factors for disease progression. So we have to control their blood pressure, but we don't necessarily need to do surgery straight away. So we can tailor the approach to each individual patient, depending on their general condition and also the disease they have. I would say in general, most of our patients present in their 40s to 70s. Patients with coronary artery disease, for example, they can come as early as their 40s, and then some are much older in their 70s, but the majority is perhaps in their 60s. But we do get younger patients, those with heart valve disease, for example, due to rheumatic heart disease. or congenital causes, they can come in their early 20s. So it depends on the etiology of the disease and also the types of disease. Family history does play an important role in this, not only because of the genetic predisposition to some conditions, but also lifestyle may be similar within families. So a family history does increase the risk of heart disease in patients, not only because of the genetic factors, but because family members may well have similar lifestyle risk factors as well for heart disease. Yes, aortic surgery is probably the most challenging of the heart surgeries we do. But the results of aortic surgery has improved a lot in recent years. We have better understanding of the aortic pathology and also the surgery which we need to do and how to do it. There's also better imaging nowadays with 3D reconstruction and very detailed analysis of the aorta. We do have a better understanding of what the pathology is even before the operation. And of course, during the surgery, we have a lot better techniques now of protecting the brain and other organs during the surgery, such as the use of antegrade cerebral protection and spinal fluid drainage. Better equipment and monitoring techniques are also available nowadays, such as cerebral oximetry and the use of cell savers to salvage blood. And of course, the aortic grafts as well and devices have improved a lot in recent years. We now have very nice branch aortic grafts and frozen elephant trunk grafts, which makes the surgery a lot easier to do. And also recently, the personalized external aortic root support increases the options that we don't need to replace the whole aorta in some patients, but we can wrap the support around the aorta to support aneurysms and prevent them from enlarging further. But in all of this, good planning in advance of the surgery is very important. We have to plan what to do. Each part of the surgery is planned in advance. The team is briefed on the plan. And this starts even before the operation. The cardiologists are involved in optimizing the patient, the anesthetist, the surgeon, and the assistants have to be briefed, the perfusionists, theater nurses, and assistants. So the whole team needs to have a good understanding of what the surgery would involve, what we plan to do, so that all the equipment are all in place and everyone knows what to do. And then, of course, post-operatively, the intensive care unit staff needs to have a clear understanding on how to manage the patient, what parameters to maintain in terms of blood pressure and the use of inotropes and so on. So the complications, potential complications are anticipated, and then there also has to be planned in place on how to avoid the complications, potential complications. And should there occur, a clear plan is there on how to deal with the complications. And of course, following important surgical techniques and principles in doing these operations is extremely important and ensures that the patients generally have a good outcome following surgery. These are extremely important control of the risk factors. For example, in patients with coronary disease, coronary disease have a whole spectrum of severity. So most patients have minor coronary disease, some have intermediate, and some have severe coronary disease. But in all of these patients, the lifestyle changes are important. So a healthy diet, regular exercise in the early stages when it's not too critical, cessation of smoking, limiting alcohol intake to not more than moderate amounts, and of course controlling the risk factors like cholesterol, blood cholesterol, diabetes, and blood pressure is extremely important. especially in patients in whom we manage coronary disease medically. A large proportion of patients with coronary disease are successfully managed just with lifestyle changes and medical treatment without the need for any interventions. And if we and if the patients follow the advice, in many cases, that's all they need. They would never need further interventions such as a stent or bypass surgery. Similarly, in patients with valve disease and aneurysms, in most of these patients, it's not severe. It's maybe mildly, the mitral valve, for example, may be leaking mildly or moderately, or the aneurysm may only be, the aorta may only be mildly dilated. So in these patients, we can control the progression of the disease through control of their blood pressure and the heart rate, if not by lifestyle changes alone, but even with medications, we can slow down the progression of this disease by controlling the blood pressure. And so this will reduce the need for surgery in these patients. And similarly, patients with heart failure, the heart failure medications have evolved significantly in recent years. So in years ago, we used to have to do mitral valve repair surgery for dilated cardiomyopathy, which causes mitral regurgitation. But nowadays, with effective medical treatment in a large proportion of these patients, we can control the heart failure and in the process also reduce the severity of the mitral regurgitation. So in patients with what we call functional mitral regurgitation, many of these patients no longer need surgery because of better medical treatment. So medical treatment is extremely important, and lifestyle changes as well. And even after the surgery, it is also important to maintain these lifestyle changes and medical treatment, because someone with coronary disease, for example, if they go for a bypass surgery, we have saved their life, we have restored the blood supply to the heart, but the disease can come back again if they continue to smoke again, and if they don't watch their cholesterol and diabetes. Problems can occur with the new bypass grafts we have occurred, and new disease can form elsewhere in the coronary arteries. So control of these risk factors and lifestyle changes is important, even after the surgery. And of course, after aneurysm surgery as well, we need to control the blood pressure. Otherwise, another part of the aorta will start dilating, or the part of the aorta we've just replaced may show problems as well. So proper medication and lifestyle changes are critically important, both before and after any heart surgery. Yeah, interesting question. Hyperhidrosis, that refers to abnormally excessive sweating of the hands, not necessarily related to heat or exercise. This is often due to overactivity of the sympathetic nerve, and this happens to travel at the back of the thoracic cavity. So various treatments are available for this. Initially, behavioral therapy in patients, antiperspirant cream containing aluminum chloride also can work, and the use of anticholinergics like oxybutynin medications. But the problem with a lot of these medications is it dries up not only the hands, but also the mucous membranes in the mouth and the eyes, for example. So if the patients continue to show symptoms or do not tolerate medications, then there's the option to do a sympathectomy. And these are done by video-assisted thoracoscopic techniques nowadays through 2 small incisions at the side of the chest, where we divide the sympathetic nerve. And this can be done as a day case, or the patients may prefer to stay overnight. So the satisfaction rate for this is 95% in all the studies. The patients generally are very pleased with the results, that the hands become warm and dry. They have side effects. The common side effects are compensatory sweating elsewhere in the body. and also sweating after meals, which is increased compared to before the surgery. But most patients report that they are not too troubled by this, and they are pleased with the results of the warm and dry hands, because in this condition, the hands can typically be so wet as to cause problems even when the patient is writing. It will wet the paper, or it will wet the smartphones they are using, and even cause problems when driving or using the computer screen. So usually it is possible to differentiate excessive sweating due to hyperhidrosis from other causes of sweaty hands, because you can also get sweaty hands from heart disease, as you say, but usually not to the extent of patients with hyperhidrosis. And of course, sweating can occur also in overactive thyroids, in hyperthyroidism, during the menopausal period, in hypoglycemia, infection, and certain cancers like lymphoma or carcinoid, so cause increased sweating. But they are typically not to the severity seen in hyperhidrosis. So with a good history, clinical examination, blood tests to exclude hyperthyroidism, for example, we can usually differentiate primary hyperhidrosis from other causes of excessive sweating of the hands, such as in heart disease. And also the age group. Most of these patients are of the younger age group, which would make certain other diseases unlikely. But in terms of combining this with heart surgery, we very rarely need to do that. In fact, I've never had to do that, because usually when you treat the causes of the heart failure, then the excessive sweating of the hand would correct by itself. Usually, if you treat the hyperhidrosis in patients only who do not have a heart condition, but there are heart conditions. Interesting that you asked this, because there are heart conditions which are treated with sympathectomy, but not because of the sweaty hands, although the treatment is the same. Long QT syndrome, for example, which is not successfully treated with medications, can be treated with sympathectomy. But in those patients, they don't tend to have sweaty hands, but it achieves the same thing as well. Oh yeah, good question. Well, all types of surgery are getting less invasive nowadays. We know from general surgery, gynecological surgery, that the use of laparoscopic techniques are well established and has replaced open surgery in a lot of the operations. In thoracic surgery, video-assisted thoracoscopic surgery is well established as well. And in cardiac surgery, minimally invasive or less invasive techniques are also emerging. In all of these techniques, particularly in cardiac surgery, when it comes to cardiac surgery, minimally invasive cardiac surgery, the cosmesis with the minimally invasive operations are better, and the recovery after discharge from hospital is also faster, because the surgery is done through smaller incisions. But of course, these are not the main factors in someone going for heart surgery, because heart surgery, as we discussed earlier, is about surviving, making the patient survive longer, live longer, have a better quality of life, and also to stay out of hospital after the surgery. So we need to look at the risks of the operation, and also the long-term results, the survival, improvement of symptoms, quality of life, and freedom from rehospitalization with the lesser invasive heart surgery techniques. And these need to be at least equal to the well-established open heart surgery, if not better than the well-established open heart surgery. And so far, unfortunately, the data does not suggest that they are better. And there is some concern with some of the techniques in terms of the longer-term outcomes. A difference between heart surgery and the other types of surgery is that in heart surgery, in a large proportion of the heart surgery we do, we need to use the heart-lung machine. We need to put the patient on the heart-lung machine to stop the heart to do the surgery. And with this heart-lung machine, generally, if the shorter the time we put the patient on this heart-lung machine, the better the patient. So the risk of the surgery is increased a bit if we have to do a longer operation because the patient needs a longer time on the heart-lung machine. And generally, the minimally invasive surgery through small incisions take a longer time to do the operation. So these patients would need a longer time on the heart-lung machine. So this does have some consequences, and this has limited the widespread use of minimally invasive cardiac surgery. But it is an evolving area, and new techniques are being developed, new instruments, new surgical instruments are being developed to allow us to do this surgery through minimally invasive techniques, small incisions. But we need to look at the outcomes, the long-term outcomes. That is how long the patient lives, how good their improvement in symptoms are, and how sustained it is, and how successful we are in keeping the patients free from hospital admissions. So we have the gold standard of open heart surgery, and the emerging minimally invasive techniques are coming, but they need to be comparable at least to the open heart techniques. I think tumors can occur everywhere, including the heart. Fortunately, tumors in the heart, when it comes for surgery, are often operable, and fortunately are not too complicated. So one interesting case was an 86-year-old lady I operated on recently, and she had this tumor which was diagnosed 2 years earlier. And because at that time she was 84, she felt it was a bit too old to go for surgery. So she waited, and during this time the tumor just grew bigger, and then it started obstructing the mitral valve, and she became more symptomatic. At that age, she was finally referred for surgery, although this is 2 years after she already decided she didn't want surgery. But when we explained the consequence of not operating, it was clear that without an operation, the quality of life would be severely impacted because of the breathing if the mitral valve gets more obstructed. So although she was already 86 years old, she finally agreed for surgery 2 years after. 2 years after she said she didn't want surgery. So we did the operation, and fortunately she did very well. She's now recovered. She's and now she wants to go for knee surgery because she's got some pain in the knee, because she's encouraged by the results of the heart surgery. So so in some patients who are very elderly, it can be about the quality of life as well, because at 86, we're not sure whether we would really improve her life expectancy, because she may die of other causes. But clearly, if we had left this problem alone, the quality of life would have been impacted. So now she is asymptomatic, she's a lot better, and she has many more years ahead of her. So heart tumors, cardiac tumors who come for surgery generally are not too complicated to do. But there are certain types of heart tumors whom we avoid doing surgery on, patients with cardiac sarcomas, for example, because these tend to be more invasive, and the outcomes of surgery unfortunately do not appear better compared to without surgery. Because in tumors, the important principle is that you have to remove all the tumor, and you can't leave residual tumors behind, because this will start growing again. And in some types of tumors like sarcomas, these have already invaded so much of the heart muscle that usually it's not possible to remove them completely. So in that case, it's actually not much of a benefit to attempt to remove those tumors. So there are some tumors which we tend not to do surgery on, whereas there are other types of tumor in which we can give very good treatment through surgery. Yes, most cases of elective coronary artery bypass graft surgery and valve repair surgery, that is elective in the elective setting, carries a risk of about 1%. There's a 1% risk of mortality or having a stroke, bleeding, infection, or organ failure. So the risk has really reduced a lot in recent years. And the risk of elective aortic surgery on the aortic root, ascending aorta, or aortic arch is about 5%. But the risk is higher if we have to do surgery on an urgent or emergency basis. If the patient with coronary disease, for example, comes with unstable angina and then needs urgent surgery, then that can increase the risk of the operation by 2 or 3 times. And similarly, if a patient with an aortic aneurysm, if they present when the aorta is already torn or dissected, and at that stage they need surgery, then the risk of surgery at that stage is much higher, it can approach about 10%. But in most cases, when we can do a planned elective operation, the risk of heart surgery is very low nowadays. Yes, I think the practice of medicine and surgery has changed a lot because of COVID-19. All patients have to be screened for COVID-19 nowadays because of the risk of infection to other patients and also to staff. And also, particularly in cardiac surgery, because COVID-19 is also an autoimmune, but also an inflammatory disease, we now know, and most cardiac surgery involves going on the heart-lung machine, which also increases or triggers an inflammatory response in the patient. So it is very important that these patients going for heart surgery do not have COVID-19, because if they do, then the risk of surgery increases very significantly in them. So we would not advise heart surgery, or we would try and delay heart surgery as long as possible in someone who has COVID-19, because fortunately in most patients with COVID-19, they are asymptomatic, and most patients recover in about 1 or 2 weeks after diagnosis. And nowadays we are able to wait in most patients for at least 2 weeks for heart surgery, but of course in some patients in an emergency, if they come with an aortic dissection, then you clearly can't wait 2 weeks, and in those patients then we have to balance the risk of the surgery versus not doing anything. But in those patients, then surgery will involve the full personal protective equipment in addition to all the other precautions in COVID-19 patients. In Malaysia, cardiac surgery in many public hospitals has also reduced because of the COVID-19, because the intensive care units have been used for COVID-19 patients, and proportion of staff have also been quarantined or are sick with COVID-19. So this has affected the activity. Fortunately, in private hospitals, it hasn't been affected too much with COVID-19. And in fact, a lot of the public hospitals are now sending patients needing heart surgery to the private hospitals, so that at least the surgery can still be maintained and patients do not wait too long for their surgery. But after the surgery nowadays, we advise the patients to stay at home and socially isolate from their friends, and just restrict visitors to close family members to prevent recovering patients from getting COVID-19, because this can be quite serious if the patient has just had heart surgery and then develop COVID-19. So this disease has affected us in terms of the precautions we need to take, and also the activity in some of the public hospitals. But fortunately, in Malaysia, we have not been hit too badly, and we are still able to offer life-saving heart surgery to most of our patients.